Hello, and welcome to another episode of MCREG International on the Go. With me is Dr. Greg Furman, who's professor of emergency medicine, and he has particular expertise in this area that I would like him to discuss. In particular, take the patient, if you would, the bleeding patient that's in the pre-hospital setting. Talk about that patient going to a critical access hospital or any hospital where they would not be the final place where these patients are treated, and then finally getting that patient to the emergency department of a tertiary care referral center, if that's appropriate.
Thanks, Brian. So this, I think we ought to refer to this as the continuum of care in a hemorrhaging patient. So I think you first start in the pre-hospital space, either in a ground EMS unit, most commonly in somebody that's hemorrhaging, where basic hemorrhage control by the EMS providers would encompass ABCs, right? So you're going to hopefully get 2 large bore IVs or intraosseous line if they're capable of doing that. Certainly a fingerstick glucose in somebody that's altered, because if this patient has a intracranial hemorrhage or something like that, it would mimic a stroke, and they will deploy all their stroke pre-hospital diagnostics that they would have. In terms of transportation, their protocol may be to transport to a verified stroke center or may go to the closest available emergency department. Regardless, some sort of notification to that hospital that you have a patient that is either stable or unstable or has stroke-like symptoms would certainly be something you'd like to communicate to the receiving hospital. In addition, certain historical features you'd like your squad to gather, which is a med list. If they're coming from a nursing home, you'd like to have a med list that might document their last dose of whatever anticoagulant they might be taking. And any therapies that have been delivered in the pre-hospital space, such as fluids, either crystalloid or otherwise, would be a meaningful data point to know as they transport to their destination hospital. Now, once they're at their destination hospital, you kind of continue that resuscitation in terms of volume expansion with crystalloid. But in a major hemorrhage situation, you're going to quickly go to blood pressure support with blood products, either whole blood or packed cells, and certainly begin to embark on some diagnostics and search for the site of hemorrhage. Now, if it's an altered patient in a stroke situation, quick transit to the CT scanner to diagnose hemorrhagic stroke or a subdural hematoma or something like that would be the first order of business, and almost treat these folks like an acute stroke patient if they come in altered. At that point in time, the ED has to assess their capabilities to further or definitively manage this patient. So do they have the ability to get a surgeon in to do source control on a intra-abdominal hemorrhage? If not, there should be a transfer agreement to a higher level of care, either preferably by air in an unstable situation. In addition, if it's a ICH or a hemorrhage in their brain, transport to a neurosurgical center would be the next order of business as well. Some of the lab work that you might deploy in the receiving hospital in the ED would certainly be CBC, renal, liver panel. You'd want to do an INR, a ProTime, and a PTT if available. Considerations towards reversal with vitamin K or 4-factor PCCs in a safety net hospital or a critical access hospital is something to be considered, because obviously a critical access hospital may not have blood products available to them, but a 4-factor PCC is something that they can stock without refrigeration and without having to cross-match blood. So a 4-factor PCC should be something that a critical access hospital can deploy for Coumadin-related bleeding. Now, you quickly embark on the question of target-specific reversal agents. By that I mean idarucizumab or andexanet alpha. Those drugs are unlikely to be available in critical access hospitals, in which case, in patients that might need that therapy, an expedited transfer, either by an ICU ground transport or a helicopter EMS would be the order of business there. Things you can do at the critical access hospital that don't entail reversal agents include, in the setting of a CNS hemorrhage, management of hypertension and ICP management would be something that the emergency physician in that location should be able to embark on, either with 3% hypertonic saline, mannitol. Managing airways would be something that would be the first thing to do in somebody that's altered and might have a CNS hemorrhage. The ability to reverse an INR to less than 1.3 and to control the systolic blood pressure to less than 160 within 4 hours of a major hemorrhage is meaningful in terms of mortality, and those should be the endpoints of therapy there. If in a setting of a major GI bleed, PPI and endoscopic therapy would be the next order of business. If that's not available at a critical access hospital, transfer certainly would be the next step.
Well, you made some very important points there, and I think that whole concept particularly is you have to know what the capabilities are, not just of your own emergency department, but also what all your consultants and your ability to be able to transport a patient, be it by ground or air. Does that make sense to you?
Without question. So a community hospital may have a lot of availability of ancillary staff, such as cath lab availability and things like that, but that may not be what is needed in this acute hemorrhaging patient. It may need to be a neurosurgeon or a trauma surgeon that is available within a half an hour to do source control, which may not be available even in very capable community centers.
That's excellent, Greg. Thank you very much. And again, you can see how important it is that you understand in these patients that are anticoagulated and have severe bleeding, that you understand the various treatments that you have for that patient, not just resuscitation, but also the potential to reverse a given anticoagulant, and also where do you transport that patient to, and how do you transport them in a fashion that will get them to a safe environment as quickly as possible. Thank you very much for watching Craig International on the Go.